Hello, and thank you for joining us today for the ShepsGME State GME Summit. We have a busy schedule today, so we'll dive into opening presentations shortly. And before we begin, I'd like to remind you that we are offering continuing medical education CME credit for attending today's presentations. Here are our CME statements, which we invite you to read when the recording of today's session is shared. And to obtain CME credit, you must complete the evaluation survey, which we will be sharing throughout the day. So now I will turn it over to Dr. Erin Fraher, Director of Policy for the ShepsGME Technical Assistance Centers, for her presentation.
Thank you very much, and good morning all, or good for some of you, and good afternoon to others. I'm delighted to be here. Thank you for the invitation. Today, I really hope to share with you why I think your role as states developing GME is incredibly well-timed and important right now in particular. So, do you want me to do the disclaimer? Sorry, this disclaimer. The content in the presentations that we're about to give is gathered from multiple sources, some of which is based on incomplete information. For example, some states have not released their applications, and it's a highly dynamic initiative. I think some of these slides might be Dr. Holmes's, so I'm going to set this up for Mark Holmes. And we're creating one deck to serve multiple purposes here. So you're going to see some slides that are hidden, etc. So we are pooling it all together, and we are looking forward to sharing this information with you. So for those of you who've seen me give a presentation before, I'm a big fan of telling you everything right up front. So I want to talk to you about something I feel pretty strongly about, and that is the physician shortage narrative really dominates this idea that we don't have enough shortage, we don't have enough physicians, but it's really the maldistribution of physicians, and not just by geography, which is typically what we think of, but by specialty and setting as well. And one of the things we know in our work in North Carolina and other places is that legislators like opening new medical schools. They're shiny, they're important, and they are important, right? But the big piece we know is that GME matters and can be more effective in influencing your physician supply. We know that federal GME training investments typically have not been aligned with population health needs, and we'll talk about that. And I also just want to say to you that what I sort of opened is that states are going to be even more important locus for health policy and health workforce policy in the coming years. And now is the time to act. How fortuitous that we're having this meeting coming together for the learning today. And there is so much that we can learn from states who are at various places along this journey of developing GME. So that is what we are going to cover today and in this slide. So the supply of physicians per capita in the United States has increased. So what you're looking at is from 2010 to 2023. You're just looking at physician supply relative to population, so per 10,000 population. And one of the things that always strikes me every year when I update this slide and I look at the data is look how much we've actually have about 6 more physicians per 10,000 population than we had in 2010. And you're going to look at the slide and you're sort of going to scratch your head and think, but that's not what I'm feeling in my state or in my region. So let's talk about why that might be the case. In North Carolina, for example, where I sit, we know that the gap between the physician supply in our metro and non-metro counties is growing. So what you're looking at is from 2000 all the way to 2023, we have looked at the ratio of physicians per 10,000 population in our metro counties, that orange line, compared to our non-metro counties in that green line. So adjusted for the relative populations in those metro and non-metro counties. And you can see that the gap in physician supply in 2000 was metro areas had about 9.5 more physicians per 10,000 population compared to non-metro counties. So that gap has grown to 14. So remember that previous slide where I'm showing you that increase in overall? But meanwhile, even though the overall supply is increasing, you see this gap between rural and urban areas. So legislators like opening new medical schools, and this is what I sort of mentioned, is that you can actually see over time we are required by the legislature to track our medical school graduates every year where they go. And you can see we've been doing this way back to 1993. But what I'm showing you is just the data from 2010 to 2019. So remember, we're tracking medical school graduates from the time that they leave medical school 5 years after they graduate. So let's look at what I'm trying to show you here. So the total number, that first line, the total number of North Carolina Medical School graduates has gone from 415 graduates up to 628. This is in part because we've expanded enrollment in our existing medical schools. We've opened a new medical school at Campbell University. So look, your overall number of medical school graduates has gone up. The percent that are initially choosing a match in primary care is held steady at about 55%. The percent in practice in North Carolina 5 years after graduation has gone from about 16% down to 10%. So our medical schools are exporting more to other states. And then look at that line at the bottom, which is the percent of our medical students who are in rural practice 5 years later. It's gone from about 3% down to less than 1%. So I take this, the take home message here is really that you can increase supply, but you're still, if we don't fundamentally change the GME system and where we are training people, we're not going to see those gains in rural communities. So the next thing I want to talk about is we also track GME. And we know you're here today because you know GME has a big impact on your healthcare workforce. And we know that it's a better predictor of where physicians will ultimately practice. So we undertake this GME tracking. We also track from when you finish your residency or fellowship, where you are 5 years later. And you can see this we did for a cohort of people who graduated from 2017 to 2018 and 2019. And you can see over time that about 39%, 40% in 2017 down to 35.8% were retained. So not only are we not retaining in North Carolina our medical school students, we're not retaining as many of our folks who are finishing residency. And so you can see the average of that 2017 to 2019 cohort, that retention was about 37%. When we did this for a cohort, an earlier cohort that had graduated residency training between 2008 and 2011, we found that 43% were retained. So like with med student tracking, we're seeing a declining percent of residents staying in North Carolina. But one of the things that really excites me is to talk about the fact that if you do both UME and GME in North Carolina, you have higher retention. This is a really important point, right? So we're meeting today about GME, but we know that there are multiple places along a physician's career trajectory where we can intervene. And creating these pathways from medical school to residency really increase that return on investment, right? Because nearly 65% overall of our people who do North Carolina medical school and North Carolina residency are retained. So compare that to 37%, right, in the previous slide. So if we can get people to do both UME and GME, we increase that retention. And one of the things that you're looking at in this chart is the retention in green is rural, and the retention in state is blue, and then the total number of residency grads. So one of the things I want to call your attention to is overall for all specialties. This is true that if you do both UME and GME in state, your retention is higher, right? So this is important for general surgery, for internal medicine, for pediatrics, for everyone. The interesting thing is that 88% of our family medicine residents are actually retained in state, which is much higher than that 37% overall. And also we see it higher, 62% for internal medicine, much higher than that 37% overall. So these pathways are incredibly important. One of the things we know from looking at just absolutely wonderful work that was done by Fitzhugh and Candice Chen and Eric Estemitz is this work that it was this, I think, seminal paper about the geographic imbalance of GME, right? And they did this wonderful analysis showing that basically GME did not align with population health needs. And let's think about this in today's system. In 2023, Medicare paid about $22 billion to support GME residency positions at about 1,400 hospitals across the United States. Only about 2% of those GME positions are funded in rural areas. So hence you're understanding the context for those initial slides, right? And we know that Medicare is funded through a formula that was based on hospital costs in the 80s and is fixed and inflexible. And the GME payments, when you actually look at it, vary significantly. And this was the work that Candace and Fitzhugh Mullen really highlighted and we thought, with any good work, let's replicate it, right? Let's update it. So we updated these data using data from 2020. And this is just basically showing you each state's rank. So in the top five, in terms of highest Medicare per population dollars, we have DC that's getting about $196 per person from Medicare funding. New York is up there at $109. So up, you see the Northeast and then Michigan in the Midwest. But then look at the bottom. So, compared to Wyoming, that's getting $2.36 Medicare GME funding per person, which is a huge disparity. And when you look at this, so basically, one of the things I want you to grab your attention is look at these states, so Texas, Montana, Idaho, Alaska, and Wyoming. And then you can see we just basically put it on a graph to show you that Medicare dollars, with the purple being the higher Medicare spending per population and the lighter being the lower. So you can see really high concentrations of the Medicare funding in the Northeast and Midwest. And I like to make this point, not just because I sit in the South where we have excellent barbecue and pretty good basketball. I like to point out that the population is actually moving south. So these were data that came from William Frey and really at Brookings, and he looked at changes in population. So where is the U.S. population moving? So of the U.S. population, where is migration happening, right? And he looked over time, various census releases of the census. And you can see that consistently over time, people have been moving to the South and away from the Northeast and Midwest. But meanwhile, that's not where we train. We train people. You can see that these data are actually from doc flows, doc flow app. Some of you have seen these data. There were data that we used from the American Medical Association master file to actually look at for each state. We wanted to give each state the data that they could look at. Where are their residents moving and from which states are they importing residents? And we did the same thing for physicians. I got this crazy idea because I was looking at a national trade map one time and I thought, wait a minute, GME is completely national. People move around. Could we capture this? And so we created this Doc Flows app. And basically what you can see on the right-hand side is those states that are net exporters of residents are in orange. And those are New York, Pennsylvania, and Michigan, those places that have a lot of GME. And then those places that are net importers of residents are California, Florida, and Texas. So what do those three states have in common? Huge population growth, right? They've opened new medical schools and they're trying to keep pace. But meanwhile, Medicare funding is fixed, right? So you see in the flows, this actual flow of people, not just population, but residents also exporting from the Northeast to the South. So it's an interesting thing to sort of compare population moves and GME training moves. So I just want to leave with you that states will be an increasingly important locus of workforce policy. If you look at, for example, the National Council of State Legislatures tracker, you can see the amount of legislative action happening at the state level has almost doubled or more than doubled. So states are doing more and more, and some of that is GME as well. And this is really spurred by the fact that states are stepping in. This was a report from 2010 from the Heritage Foundation, where I thought they really encapsulated a lot of the same themes we're seeing today, where not enough doctors, too many. Maybe it's the states that have to solve the problem. And they argue in this paper that states are far better equipped than the national government to address increasingly complex and serious health workforce shortages. I bring this to you because it is sort of the current context of where we're looking is states are stepping up saying, New York is not exactly the same as Wyoming. So the differences between those states allow states to really tailor their GME policy to their state health workforce needs. And this is basic for those of you who are Jeffersonians. This is basically the concept of federalism, right? This idea that there are federal powers and there are state powers. And this workforce policy sphere is one of those things that's shared between the federal government, right? The responsibility for shaping the size and distribution and composition of the health workforce is really shared between states and the feds. And each level has its own authority. And this is an interesting paper from Harvard because it points out that it really enables you in your state to stay close to what the needs are. Some of you will have needs for primary care and general surgery and psychiatry. Some of you will need dermatologists and endocrinologists. Like, you are the closest to understanding what your workforce needs are and to designing GME that allows you to meet those needs. And you today, you'll see throughout this call and throughout this meeting that states really are what we think of as policy laboratories for GME innovation. States have differing population health needs, as I just mentioned. You have state appropriations and Medicaid dollars that give you a lot more flexibility than, and others will talk about this in your GME 101 and finance presentations today, a lot more flexibility to design those financing mechanisms to meet population health needs. You can not only design it where it goes, you can think about the balance between whether you want to develop new programs, expand existing programs, and provide technical assistance, any combination of those things, right? And states, you are closest to also having the data about your state and being able to measure the return on investment. So you can say we spent X Medicaid dollars this year, and here's what we actually got in return. And we're going to talk about that today too. And workforce data, I believe this because I'm an egghead, are absolutely critical to this, right? Because next time you go to the legislature and you want to say, we need X number of positions, we need new GME funding, either through state appropriations, Medicaid, some other financing mechanism, you can show the return on investment. Hey, we've increased the number of people practicing in this underserved community in primary care due to this fact that you helped us fund these GME positions. So that provides sustainability funding as well. So the last thing I want to say is just how important, how honored I am to be here, to think about how we share best practices and learning, and grateful to be able to have this opportunity to share it with you. And I will happily share the slides and some of the citations as well. So thank you very much. And I think I'm turning it over to my colleague, Mark Holmes.
Thank you, Erin. I don't think anyone here expected to get a reference to Jeffersonian democracy or federalism, but appreciate the continuing political theory education option for that. So, okay, so Erin mentioned or had a slide about the disclaimer in there that was referencing a lot of incomplete data that we'll be doing our best with. And this really does pertain more to what I'm going to be talking about, which is the Rural Health Transformation Program. And I'll be giving some more of that disclaimers in a little bit. But Dr. Fraher taught me this talk in one slide approach, and I'm going to do that here. RHTP, which I'm assuming here everyone has heard about, is a major, time-limited investment in rural health. States that have developed proposals that meet the specific needs of their state. That's another federalism reference, right? And that each state sort of looked at what they have in their specific needs and designed their response to that around that. Almost all states are addressing workforce in some manner, but not as many are looking specifically with GME, using GME as the tool. And it's this button here. Okay, so just a brief history of the Rural Health Transformation Program. Mid-June 2025 as HR 1 really started to come together, and people really understood what the effects of the Medicaid on rural hospitals were starting to look like. A number of U.S. senators advocated for this RHTP, or sometimes fund. I always like to remind folks that H is for health and not hospital. July 4th, it signed into law with $50 billion across 5 years to transform rural health. Not a lot of details to the specific elements of RHTP. The rest is left to CMS to design and implement. And it just does need to be said that I like to think about HR 1, Medicaid, Medicare, and other effects separately from the RHTP. But the $50 billion in RHTP is one-time money over 5 years, whereas the GAO estimated $137 billion over 10 years in terms of decreases into rural providers. NOFO dropped September 15th. Applications were due 51 days later, and then state awards were announced on December 29th. So it was a lot happened in those 6 months. As you look back on the NOFO, the Notice of Funding Opportunity that was for the RHTP, there were 5 strategic goals outlined here. Not going to get into each of these, but there is a specific call out for workforce development, looking at attract and retain a high-skilled healthcare workforce, providers in rural communities, Note that it specifically calls out community health workers, pharmacists, and individuals trained to help patients navigate the healthcare system. Physicians are not specifically listed. There's a broader a very broad interpretation of workforce here that you're going to see as a theme going continuing. The RHTP funding there's a number of stipulations in how this cooperative agreement is implemented, with aggressive state accountability, annual review of progress with milestones. Unobligated money is returned to the funder, reallocated to a pool that then gets reallocated. So it is better for my state if you don't meet your goals and don't spend all your money. And so there's a high incentive for states to move quickly and really do this implementation efficiently. One notable note is that these applications were by the governors of the states. In many states, that worked great, and there was time to work with the legislature and come up with something that met both of their needs. But with the 51 days, it was often accelerated, and not all legislatures are supporting the plan that the governor put forth and CMS approved. And Idaho is a leading example where the legislature is trying to decide whether they want to accept or return this money. That's oversimplification, but there's some review of whether the Idaho RHTP will actually be implemented. The implementation strategy places a premium on earlier wins. There needs to be a sustainability plan. And what these last 2 points in particular may influence what states looked at from a GME strategy, and a need for early wins that are sustainable in order to meet the goals. So we have pretty good but incomplete information about what is in these applications. Most states released their application in one form or another. There have been some attempts to summarize some of the notable activities there, but we don't know what was ultimately approved. These are cooperative agreements, and so what was ultimately negotiated may be different than what was in the proposal. The conventional wisdom is not a lot of change, but we don't really know for sure. So what we did is we took all the applications we could find and the summaries when available, ran them through some AI, and said, what are the themes? What are states doing? And created what I'm calling this as a pill chart, which is sort of filled in. They look kind of like colored pills to me. Looking at some general themes in what states are doing. You could see most states are doing something in tech and digital. And notably in the yellow group there, that's the workforce group. And we can see there that just about every state did workforce. Now, if you're in Louisiana or Wyoming, you may say, hey, we're doing workforce. It didn't get picked up, or there might be another state that didn't do it. That's AI for you. Probably a pretty good sense of sort of what the common themes are. And I think I'm comfortable concluding that workforce is a very major theme across the state applications. Now, that being said, workforce is a big theme, but GME is not really. And although most states did something in workforce, we're really seeing a lot of that focused on non-physician workforce, CHWs, nurses, for example. And the initiatives that are physician-related tend to be more around recruitment and retention, less about specifically GME. Some proposals are ambiguous. Again, I think this is a consequence of the 51 days and only having I don't remember how many pages they had allocated to the narrative, but there are a lot of references to rotations and residencies around workforces that may mean physicians. If you look at it, I'm generally concluding that many of these places are not really speaking about GME in particular. So I want to just spend a couple minutes and highlight some of the notable examples that we've seen that we can see here. Here's the one I'm most familiar with, which is North Carolina. And we could see here specifically listed, this is right out of there, launching rural residencies and fellowships. And this is the main strategy out of what North Carolina will be doing. And I'm really crossing my fingers that Indiana is going to be one of the ones I highlighted here. Washington proposed to use the WWAMI consortium to expand family residencies in Washington state with 4 more clinical residencies as their goal by 2030. Maine is using the Consortium for Healthcare Education and Training, or CHET, to expand residencies. Iowa doesn't have a lot in GME per se, on GME per se, and RHTP that seem to be funded by RHTP, but there's references to state actions, including the supplemental enhanced payment for GME, and thinking about how those are going to work together and complement each other. I think that's a really interesting strategy that's in some of these applications is the states stepping back and seeing RHTP as one piece of the strategy, but paired with other state actions or maybe other things that they've been doing in the all along anyway. Two other states, and sorry, Brooke, I'll put Indiana in here after I take a look at that. Wisconsin has quite a bit of activity looking at a new rural dentistry residency through Marquette. And then campuses will be replicating evidence-based models to expand rural training for disciplines as listed here, including primary care. But again, notable that that this is another example of a strategy that's looking beyond primary or physician and GME, but thinking about other workforce specialists as well, or taxonomies. And then North Dakota looking at new physician residency training slots, including tribal specific residencies. So looking at that as a specific population. Okay, last slide. So a little faster than I budgeted. Apologies for that. But RHCP represents a generational opportunity. I'm italicizing opportunity there just for those of you in this space. There's a lot of promise of what RHTP can bring. And I think many of us are watching the next 6 months to really see what it's going to look like as states start to implement those and see is the promise following through with how it's being operationalized and is it making the difference in the rural America as Congress intended. Most, if not all, states are doing something in the workforce space, but again, GME is a less common strategy than certainly I had expected. My prior was that GME would be a real common theme across these. We know that rural GME is of high interest, and I had expected there are that to be a core component of most states' strategies, or at least many. And then an open question is that will there be flexibility in the state implementation to include more GME work? And what I mean by that is if you read all the official guidance, starting with the NOFO, all the FAQs, all the language that CMS has been putting forth around the RHCP is this is the plan that you submitted on November 15th. This is the plan that you're going to have for the next 5 years. I expect, I'm hopeful maybe is a better term, that there will be some ability for the states to tailor their responses as we learn more about what's working and what's not. I think the promise of RHTP is, yes, $50 billion to be directly invested into rural America. And we're going to learn a lot over the next 5 years about what works and what doesn't. The very federalist approach and how each state is doing something different. And we got different initiatives going over here. And again, North Carolina is the one that I'm most familiar with. Even within North Carolina's design, there's a number of optional activities around the Make Rural America Healthy Again strategy. And let's do something with maternity health. Let's do something with, tobacco use. And so we're going to learn a lot about what works and what doesn't. I am hopeful that CMS is going to be looking at the early lessons out of the states and saying, all right, this is working really well. This is a strategy that isn't, and allow the states to respond to that, probably within the broad framework of sort of what they're thinking. But all this is to say, if you're in a state that did not have GME enlisted in its RHTP, my encouragement would say, don't give up yet. Look at what's in there. Is there a way that you can think about GME? For example, working on prevention and primary care, GME may be a strategy as part of that goal. And so there may be opportunities to get maybe not another bite at the apple, but I'm not willing to say these things are locked down for the next 4.5 years. I'm hopeful that there will be some learning and adaptation as we proceed. But officially, no, but watch this space, I guess.
You for being part of today. And the main take-home message that we want you to walk away with today is that you are not alone. We are stronger together and we're here to support you. So in that, I want to share some resources that are available to any of you to help in your respective states. We have a toolbox of resources that are available across multiple different specialties and different domains of residency development and sustainability. Encourage you to check them out at www.ruralgme.org or thcgme.org. We also have a roadmap for how to get started and a list of all the objectives. I think there's 165 of how to launch a program. Please use our resources, and those are available within our portal. We also have an analyzer. What I want to thank Mark Holmes and his team, Mukesh, who have worked really hard in developing this. It provides a report out for every single hospital in the U.S. and gives, nuances around funding eligibility and CMS funding as well. We also have a glossary that is paired with that is really helpful in kind of drilling down some of the nuances around GME funding. We have a prime rural hospital list that really is based on kind of a logistic regression that picked out rural GME naive hospitals that have never engaged in training that seem to meet the financial characteristics. And what's really rewarding as we're engaging with different states and through our federal work, that many of these prime rural hospitals are actually starting programs. A new tool that we just did in relation to rural health transformation is we created a never claimer hospital list for you. This is accessible on our website. It shows every single GME naive or a hospital that's never claimed cost according to their CMS cost reports on our tool, and we hope it's helpful to you in your state. We have a rural training site map that is filterable by specialty and state. If you are engaged in training, we're about to update this with our latest ACGME data, but if you see something that's not correct or want to be on there and you're not on there, please let us know. This is really kind of limited by kind of the data that we have, and we really want your program to be highlighted or your state's programs to be highlighted. We also have a health center training map and encourage you to check that out as well. A couple of last remaining reminders for you all. Kelsey George with NCSL provided a great link a database that's available through NCSL that I want to make sure if we could pop that in there again. If you have a resource that's helpful to you that you think our audience needs to know about, please go ahead and just drop it in the chat. Again, we don't want to reinvent the wheel. We want to make sure that we're sharing existing resources. And then finally, I want to share that we have a national network open to anyone, a health center administrator network open to medical and dental programs. We have a teaching health center DIO network that we do in collaboration with ACGME. We also have monthly webinars for health centers and rural programs that are open to anyone. And then last but not least, our annual meeting, which just gets to feature many of the wonderful federal and state partners that we are just honored to work with. ACGME comes to our annual meeting every year and does one-on-one site visits. We hope that you'll consider coming. It is open to anyone, and so we look for, there's nothing like in-person connection. This Zoom time today has been wonderful, but really there's more power in that in-person connection. So thank you again, and with that, I'm going to ask Heidi Miller with the Department of Health and Human Services at Missouri, who is really leading their work in Missouri, to close us out with why this work matters.
Yeah, and I also want to tip the hat to my colleagues, Alicia and Clarissa, who've been integral. So thank you so much for an exceptional summit. The ShepsGME Center has been an incredible resource to us. I'm a federally qualified health center primary care doctor, have seen patients for 23 years. And when I took the job 3 years ago to be the chief medical officer for the state, my boss told me, Heidi, I need you to grow more primary care doctors in the state of Missouri. And I just gulped and felt faint and thought, well, if that were easy to do, it would have been done already. That's totally daunting. How do I do this? And I literally searched the medical literature and cold called this professor named Erin Fraher, because she'd published a lot of smart papers about how to do this across the country. And then she introduced me to her team of superheroes, with special shout out to Lori and Emily and a number of you who have helped our state so much. We needed a lot of hand holding. And I realized not only is it normal, but the hand holding itself through this technical assistance has been very effective and with a high return on investment for that. One of the exciting things about this is, despite some bipartisanship across our country, I have found that this issue unites every legislator that we have spoken to in the state of Missouri, red or blue or independent, every single one of them has patients in their district who need doctors. And once they understand what GME is, and none of us should assume that anybody else does besides those of us who are here, there is so much support for this. And then just two quick things. One, as we communicate the need for this, we continue to value the team, which our nurses, our nurse practitioners, our PA assistants, but the way that the ratio has fallen by the wayside for physicians is very, very concerning for public health. And in Missouri, we've framed the lack of GME and the lack of physicians as a major public health crisis. And it's absolutely fixable. And thanks to a lot of your best practices that were shared today, peer pressure is a very helpful tool, whether it's in middle school or if it's in the national policy scene, to be able to know that like there are other states that are doing this so well. I like to tell Missouri that Wisconsin has run out of HPSAs, or they're running out of HPSAs. We'd love to have that problem too. So thank you so much for today. This was really educational.
Thank you, thank you, thank you, Dr. Miller. And again, want to acknowledge McKenna, who really led and facilitated our work. Thank you all for engaging today. And any closing thoughts, McKenna?
No, thank you all again for your support and your participation. This was a great event today. I'm so glad so many people were able to join.
Enjoy your afternoon. Thank you all.